Welcome to the Deep Dive. Today we're tackling a topic that demands absolute focus from any medical professional. Pediatric Advanced Life Support, PALS.
It's definitely a high-stakes area.
We've been going through the PALS Provider Handbook, and our goal today is to really pull out the blueprint, how to make those rapid, life-saving decisions when a child is in crisis.
Right. And for you listening, whether you're a resident, paramedic, a nurse, the mission isn't just memorizing steps, it's about internalizing the whole systematic approach.
It's a framework, isn't it?
It is. PALS is basically the consensus of experts, all boiled down into rules simple enough that you can actually recall them under incredible stress. It's designed to bring order to chaos.
And what I love about it is how universal that framework is. Maybe you could be using these principles at the roadside with almost no equipment, and that structure is still there.
Absolutely. It all comes back to mastering the basics, the BLS, and just being incredibly rapid and accurate in your assessment.
So before we even get into the clinical side, we have to talk about the team.
We have to, because a resuscitation can be anything from a single person finding a child, in the community to a huge team in a trauma bay. Team dynamics are they're non-negotiable.
The handbook is really clear on the roles. You've got the team leader, who's the organizer, the director.
For monitoring everything. Critically, they're also the one who gives feedback after the event. That's so important for learning.
Then you have the team members.
And every member has to know their role, be skilled in it, and be committed. The secret sauce is closed-loop communication.
Can you give an example of that?
Sure. If I, as the leader, say, administer 0.01 millikilogram of epinephrine, you don't just do it.
You repeat it back.
You repeat it back. Confirming 0.01 millikilogram of epinephrine, then you give the drug, and then you report back, epinephrine is in. That clarity cuts right through the anxiety of a code.
Okay, so let's shift to the absolute foundation of PALS, high-quality CPR.
This is where we see a huge break from adult protocols. You have to be so meticulous about the differences.
Between infants, so that's 0 to 12 months, and children, which is 1 year up to puberty.
Exactly. The differences start right away with just checking a pulse. On an infant, you're going for the brachial artery.
High up on the inner arm.
Right. Trying to feel for a neck pulse on a chubby infant it's really difficult. For children, though, you can go for the carotid or the femoral.
And the actual compression technique is different, too.
Completely. If you're by yourself with an infant, you use 2 fingers on the sternum. But if you have a second rescuer, the 2 thumbs encircling technique is much better.
Because it generates higher pressures, right?
It does. It's just more effective. For children, you move to 1 or 2 hands, whatever you need, to get the right depth.
And that depth is key.
It's critical. The target is about 1/3 of the chest depth. So that works out to about 1.5 inches for infants and 2 inches for children.
Now, here's where I think the biggest pediatric distinction comes in. The compression to breath ratio.
Yes. So for a single rescuer, it's still 30 compressions to 2 breaths. Same as adults. For all ages.
But the moment a second person shows up, everything changes.
It tightens to 15 compressions to 2 breaths. For both infants and children.
So why is that? What's the thinking behind prioritizing breaths so much more in kids?
That 15.2 ratio is it's a core PALOS insight. We focus on ventilation way more in kids because the vast majority of pediatric cardiac arrests happen after respiratory failure or shock.
So their heart gives out because they've run out of oxygen.
Precisely. Their primary problem is almost always respiratory. And those 2 breaths every 15 compressions are often the most important part of the resuscitation. It's what they need to recover.
That one detail really changes how you approach the first few moments.
It does. And it even affects when you call for help.
Right. So if you see a child suddenly collapse, a witnessed arrest, what do you do first?
You activate emergency response. You grab the AED immediately. But if you find them unresponsive, an unwitnessed arrest, you do 2 minutes of CPR before you call for help.
Again, because the problem is likely respiratory.
Exactly. Those first 2 minutes of high-quality CPR can be the difference between life and death.
Okay, so moving from BLS into the core of the PALS process, the initial assessment, the ABCDEs.
This is your rapid-fire tool to assess perfusion and oxygenation. The goal is simple. Diagnose and intervene. Right now.
So, A is for airway.
Is it open? Is it patent? Do we need to reposition the head? I mean, if the airway isn't open, nothing else we do is going to matter.
Then B for breathing. We're looking at rate, effort,
and effectiveness. Yeah. And here's where you spot the signs of impending doom. You look for the obvious things, nasal flaring, retractions, grunting. But you also have to look for bradypnea,
Slow breathing.
Abnormally slow breathing. That is a massive red flag in a child. It means they're exhausted, their respiratory muscles are giving out, and arrest is coming.
And you have to be able to tell the difference between real breathing and just gasping.
Agonal breathing, yes. It's ineffective, and it means you need to start bagging them immediately.
C is circulation. This is more than just a pulse check, right?
Oh, much more. You're looking at the whole clinical picture: skin color, temperature, and capillary refill time.
If you press on the nail bed and it takes longer than 2 seconds for the color to come back.
That's inadequate perfusion. Full stop. And you also have to know the age-specific cutoffs for hypotension.
There's a formula for this in the handbook.
There is, and you need to know it. For kids aged 1 to 10, the minimum systolic blood pressure is less than 70 plus, 2 times their age in years.
So for a 5-year-old, that would be 70 plus 10, so 80. Anything less than 80 is hypotension.
Correct. And you need to be able to do that math instantly. Seconds count.
Next up is D for disability, the neuro check.
The quick and dirty way is the AVPU scale. Are they alert, responding to voice, responding to pain, or unresponsive?
But there's a more detailed scale, too.
Yes, a modified Glasgow Coma scale. And it has to be modified because, a 6-month-old's verbal response is going to be different from a 6-year-old's. The scale accounts for things like an infant's ability to coo and babble.
Finally, E is for exposure.
Look for trauma, look for burns, but critically, you have to manage their temperature. Kids lose body heat so much faster than adults.
So you have to cover them and warm them up as soon as that survey is done.
Immediately. Hypothermia makes everything worse.
And if the patient is stable after that initial A, B, C, D, E, we can move on to the secondary survey.
Right. That's when you can take a moment to get a history using the SPAM mnemonic, signs and symptoms, past medical history, allergies, and medications.
Great. Let's move on to the tools of resuscitation. When you can't get an IV in a crashing child, which is common, what's the next step?
Intraosseous access, the IO. It is absolutely essential.
You're going right into the bone marrow.
You are. Think of the bone marrow as a non-collapsible vein. Anything you can give IV, you can give IO. And this is key with no dose change.
Are there any times you can't use an IO?
The contraindications are pretty common sense. You can't drill into a fractured bone or if there's an infection at the site.
Okay, airways. Let's talk OPA versus NPA. There's a huge rule for the oropharyngeal airway, the OPA.
A hard and fast rule. It is only for a completely unresponsive patient, someone without a gag reflex.
Because if you put it in someone who's semi-conscious,
you'll make them vomit and then they'll aspirate. It's incredibly dangerous. The NPA, the nasopharyngeal airway, can be used in patients who are conscious, but you have to be careful with facial fractures.
And what about the AED, the automated external defibrillator?
The criteria are simple. No response, no effective breathing, no pulse. The caveat with PLS is size.
Right.
For infants under a year, a manual defibrillator is preferred. For kids 1 to 8, you have to use pediatric pads and a dose attenuator if you have them.
And if you don't, if all you have is an adult AED,
you use it. An adult shock is better than no shock at all.
Good to know. Now let's get into pharmacology. Far ear IO is always the preferred route for drugs. Why do we avoid the endotracheal tube route?
It's too unpredictable. Absorption through the lungs is all over the place. You have no idea how much drug is actually getting into their system.
So let's run through the big ones. First up, epinephrine.
Epi is the workhorse. You use it in cardiac arrest, some types of shock. The IVIO dose is always 0.01 milligrams per kilogram.
Given every 3 to 5 minutes in a code.
Every 3 to 5, regardless of the rhythm. Next is adenosine. This is for stable supraventricular tachycardia, or SVT.
And the key here is how you give it.
It has to be a rapid push, a slam. It has an incredibly short half-life, so you follow it immediately with a saline flush to get it to the heart. Max first dose is 6 milligrams.
Okay, what about for bradycardia, a slow heart rate? We use atropine.
We do, but there's a minimum dose you have to know.
Why is that?
Because if you give too small a dose of atropine, you can get something called paradoxical bradycardia. It can actually make the heart rate slow down even more.
Which is the exact opposite of what you want.
The exact opposite. So the minimum dose is 0.1 milligrams, no matter how small the child is.
And finally, a big one, hypoglycemia, low blood sugar.
Defined as 60 milli-GDL or less. The key here is that the concentration of dextrose you give changes with age. It's a fluid and osmolarity issue. For newborns, you use a lower concentration, D10W. For infants and children, D25W. And for adolescents, you can use D50W, just like in adults. You have to get that right.
This brings us to the most complex part, the clinical protocols. Let's start with respiratory distress and failure.
As we said, this is almost always where pediatric arrests begin. We think about the causes in 4 categories: upper airway, lower airway, lung tissue disease, and CNS problems.
And the treatment has to be specific to the cause.
It has to be. You wouldn't treat croup, which is an upper airway problem.
Swelling in the trachea.
Right. You treat that with steroids and nebulized epinephrine. You wouldn't treat asthma, a lower airway disease, the same way. For asthma, you're using albuterol and corticosteroids. The diagnosis guides the therapy.
Let's move to arrhythmias. When do we actually treat bradycardia?
Only when it's symptomatic, so a heart rate under 60 and signs of poor perfusion. If you have both, you start CPR and give epinephrine. Atropine is next if that doesn't work.
And for tachycardia, a fast heart rate.
If an infant's heart rate is over 220 or a child's is over 180, the heart doesn't have time to fill properly between beats. Cardiac output plummets.
So you have to figure out what kind of fast rhythm it is.
Quickly, is it sinus tachycardia, which is usually from fever or stress, or is it SVT?
What's the giveaway?
SVT is usually an abrupt, sudden onset, a rock-steady fast rate, and you often can't see P waves. Sinus tach is more gradual, and the rate varies a bit.
And if you see a wide QRS tachycardia,
You have to assume it's ventricular tachycardia, VT, until proven otherwise, it's a killer. If the child is unstable, you go straight to synchronized cardioversion.
how much energy do you use?
You start low, 0.5 to 1 joule per kilogram, and if that doesn't work, you double it to 2 J-kilogram for the next shock. If it's a stable, narrow, complex SVT, you try adenosine first.
Okay, let's talk about shock. The definition is inadequate oxygen delivery to the tissues.
And the big challenge is telling the difference between compensated and uncompensated shock.
Compensated is when the body is still fighting.
Exactly. Heart rate is high, vessels are clamped down, but the blood pressure is still holding on. It's still in the normal range. Uncompensated shock is when those mechanisms fail and you get hypotension. You have to catch it before that happens.
We break it down into 4 types: hypovolemic, distributive;
Which is things like sepsis or anaphylaxis.
cardiogenic, which is pump failure; and obstructive.
Right. For most types, like hypovolemic and distributive shock, the treatment is aggressive fluids.
What's the rule for that?
The rule is 20 milliliters per kilogram of an isotonic crystalloid-like normal saline given as a bolus over 5 to 10 minutes. And you can repeat that as needed.
But that strategy gets flipped on its head for cardiogenic shock.
Completely. If the pump is broken, flooding it with more fluid is only going to make things worse. You'll cause pulmonary edema.
So what's the approach there?
It's a much more cautious fluid bolus,
Yeah.
maybe 5 to 10 milliamperes given slowly over 10 to 20 minutes. But the real focus is on inotropes drugs like dopamine or milrinone to make the heart pump better.
When we get to actual cardiac arrest, we always have to be thinking about the reversible causes, the H's and T's.
Hypovolemia, hypoxia, hydrogen ion or acidosis, hypo or hyperkalemia. The list goes on. You have to be thinking through them constantly.
And the rhythms are broken down into 2 main groups.
Shockable and unshockable. Shockable is VFib and pulseless VT. Unshockable is PEA and asystole. But for all of them, high-quality CPR is the absolute foundation.
For the shockable rhythms, what's the energy dosing?
First shock is 2 joules per kilogram. Second shock, you double it to 4 J kilograms. And you can go up from there to a max of 10 J kilograms. Epinephrine is still given every 3 to 5 minutes, and amiodarone is the drug for refractory VF or PVT.
So let's say all of this works. We get ROSC, return of spontaneous circulation. The crisis isn't over.
Not at all. Now you have to pivot immediately to post-resuscitation care.
What are the goals there?
It's all about preservation. For the lungs, you optimize oxygenation. You want the SpO2 between 94% and 99%. You have to avoid both too little and too much oxygen.
And for the brain, neurological preservation is huge.
Paramount. You treat any fever aggressively, you make sure their blood sugar is stable, and if the patient is still comatose, you consider therapeutic hypothermia, cooling them down to about 32 to 34 degrees Celsius to protect the brain.
You're also watching the heart and kidneys closely.
You're using vasopressors to keep the blood pressure up, tailored to the cause of the shock, and you're making sure they're making urine at least 1 ml per kilogram per hour. That post-arrest care is what so often determines the ultimate outcome.
That was an incredibly thorough run-through of the entire PALS protocol. It's so clear that the system, the fundamentals of BLS, and just knowing those specific pediatric doses, that's everything.
It really is, and the whole philosophy of PALS is about prevention. It's about catching the problem early, recognizing that slide from respiratory distress into failure or from compensated to uncompensated shock. That's how you really save a child's life. You intervene before their heart stops.
So for you, our learner, let's try to make some of this stick. Let's do a quick application question based on what we've just covered.
Oh, here's the scenario. You're managing a 9-year-old child who is in compensatory septic shock. It's presenting as warm shock, which is a type of distributive shock. You've just established IV access. What is your immediate fluid intervention? I want you to think about the type of fluid, the dose, and the administration time.
Yeah.
And why is that fluid resuscitation so critical before you even think about starting vasopressors in this specific type of shock?
Take a moment and just walk through that PLS algorithm in your head. That
Yeah.
systematic approach is what underpins it all. Thank you for joining us for this deep dive. Keep practicing, keep those skills sharp, and we'll talk to you next time.